Good afternoon to everyone. This is Dr. Krithika and my number is 03460. So here am I present the paper of iris claw versus SFIOL in aphakia corrections. So we all know the causes of aphakia are complicated cataract surgery, traumatized eye, ectopia lentis, and many subluxated or dislocated lenses. And there are various modalities to treat aphakia, that is via spectacles, contact lens, or IOL implant. Now, without posterior capsular support, techniques for IOL implant are anterior chamber IOL, iris fixated IOL, or SFIOL, that further divided into suture fixated, sutureless, or glue fixation. So, aim and objective of this study is to compare the outcome of the posterior iris claw lens and cerebral fixated posterior chamber IOL lens, IOL, in terms of best corrected visual acuity, post-op stability, and centration of lens, and post-operative complications. So a comparative study of 60 cases with 13 each group 1 of iris claw and group 2 of SFIOL. The pre-op and post-op visual acuity was compared, and slit lamp fundus application tonometry was done, biometry, OCT was done for extensive evaluation of anterior and posterior segment. The shim-flux imaging was used to evaluate the proper centration of IOL after the surgery. Now SFIOL was done as the peribulbar anesthesia was given, 5 mm conjunctival peritomy was done at 2 to 8 o'clock position. 2 T-shaped incision were given from limbus 180 degrees apart, and we did deep core anterior vitrectomy if needed. The sclerotomy was done by 23 MVR gaze at a point on the incision parallel to the limbus, and the stellar tunnel was formed at the intersection of the T incision. I will just show the diagram in the next slide. And the implant was done of 3-piece IOL through corneostellar incision at 10 to 12 o'clock position. This is the diagram that I was saying. And the both haptics was externalized through the sclerotomies, and the haptics were buried into the tunnel, and the stellar incision was closed with 80 vicryl, and the conjunctiva was also closed with 80 vicryl. For iris fixated IOL, the 5 ml corneal stellar tunnel was made at 12 o'clock position, and the IOL was inserted into anterior chamber with convex sign downward with the help of IOL holding forceps. And we brought the haptics of the IOL at 3 to 9 o'clock position, and we tilted the IOL to visualize the contour of claw through the iris stroma. And with the help of DIR, we fixed the center of the haptic with iris tissue, and also we did the peripheral iridectomy. Now results were, the mean age in the iris claw group was 57.25 years, and in SFIOL group was 58.88 years. The changes in the K1, K2 and astigmatism and was more in iris claw group, but statistically it was insignificant in both the groups. Now, change in the BCVA and UCVA after surgery was found significant in both the groups. Post-operatively, IOP was slightly higher in the iris claw fixation group in comparison to the cerebral fixation group. On day 1, there were 3 cases of corneal edema in the group 1 and 1 case in group 2 due to surgical manipulation, which got resolved in the next follow-up. There were 4 cases of opening of pupil on day 1 with iris claw, and also 2 cases of pigment dispersion in iris claw IOL. On day 7, there were 3 cases of raised IOP in group 1 and 2 cases in group 2, that was of SFIOL, which were managed medically, and one, that is 2% case of decentration, was present in group 1 of iris claw, which was recentered surgically. At 3 months, there were 2 cases of decentration in group 1 of iris claw, which was recentered surgically. That was, I already have said. Surgically, time was significantly less in iris claw fixation group. The SFIOL takes much of time, and at the end, all have well-centered IOL with good visual acuity, that's shown in the picture. The first one is of multipace IOL as seen on the slit lamp, and another one is iris claw on the slit lamp. Now these are the shim-flux imaging that shows the well-centered IOL in both the groups. And so for discussion, both the techniques had similar good visual result, although operating time was much shorter for the iris fixation, but it had several disadvantages, like that included astigmatism, immediate post-op inflammation, ovaling of pupil, pigment dispersion, and that makes the self-fixation IOL a better choice. Thank you so much.